The topic for discussion today is anomalies of face, that is during development. These anomalies of face are usually these anomalies or malformations of face are usually because of any disturbance during the growth phase, during the growth or during the time of development. If there is any disturbance, it can lead to anomalies of this face. Anomaly is actually a medical term which means irregularity or different from normal. That itself explains that these anomalies usually make the face, or in the process of development, it is not normal in origin. I mean, it is not normal in course. Because of any deviation from this normal course, it can lead to an anomaly. These anomalies are usually either evident at the time of birth, or they can be seen in due course of development of during the growth phase. If they are rightly present from the birth, they are actually called as congenital, and if they are during in the course of the growth phase, then they are called as developmental in origin. So this is a picture which is actually showing us before knowing the developmental anomalies, how the development of face has occurred. So I'm not going to detail much because we will deal about this in the embryology topic. So coming back to our developmental anomalies, we have various etiological factors for this anomalies. It is actually a multifactorial in origin or multifactorial in etiology. The most common one is combination of genes, that is in mutations of the genes. It could be a genetical in nature or familial in nature. Because of these genetical issues, there could be either chromosomal aberrations or a Mendelian inheritance leading to these anomalies of face. Other one could be a folic acid deficiency. This folic acid deficiency can lead to neural tube defects. Thus, it can again lead to other anomalies of face that has been developing from the neural tube, that is ectodermal in origin, and it can also lead to various syndromes, the congenital anomalies within the syndromes. That is the reason to avoid this folic acid deficiency and further anomalies of the the fetus, what they do is before planning for pregnancy, the folic acid supplements are being given to the females to in the childbearing age group, so that the folic acid deficiency can be avoided in these conditions. And other factors include environmental factors. Environmental factors includes a maternal illness. Maternal illness is when the mother is carrying a child, then in those during that phase, if the mother is being affected with any conditions such as diabetes mellitus or any other endocrine diseases or acute fever conditions, then the child could also be affected because of this maternal diseases. And viruses like rubella, cytomegalovirus, HSV and syphilis can lead to changes in the fetus, again leading to some anomalies. That is the reason in syphilis we see congenital syphilis, right? We have Hutchinson strand there, again we have depressed nasal bridge. All these conditions could be seen in case of this syphilis. And then various drugs and chemicals like folic acid antagonists, androgens, phenytoin, thalidomide, etc. can also lead to changes within the fetus. There is something called as teratogens. Teratogens are something, an agent which can produce congenital anomalies. Okay, these are called as teratogens, and the drug or any material that can lead to these anomalies are known to have a teratogenic effect. Okay, the basic principle of this teratogenesis is nothing but what is the critical period of development. So these teratogens have to be taken or should have been taken during that critical period of growth. For example, in the first 3 months of intrauterine life, organogenesis happened, right? So certain teratogens can hamper this organogenesis. This can lead to teratogenesis, and that can further lead to anomalies of the child, or the facial anomalies or any congenital anomaly. Dosage of a drug or chemical can also govern our teratogenesis. Again, the genotype, that is genetic constitution of an embryo, can also govern teratogenesis. We have various developmental disturbances of face. Apart from, we have seen about the etiology. Now we're going into various developmental anomalies of the face. Coming back to the first one is developmental anomalies of the jaw. In this, first one is micrognathia. Micrognathia, as the name itself indicates, it is smaller jaw, right? The jaw is smaller than the normal size. This can be of two types. One, it is apparent, and one, it is true. Apparent is nothing but a relative one. In this relative or apparent micrognathia, what happens is the tooth size are usually larger in size, making the appearance of jaw smaller. Okay, here what happens is the jaw is not smaller in size. Because of a relativeness, that is the teeth and the jaw. The teeth are larger in size and hence the jaw appears to be smaller in size. That is relative or apparent one. We have something called as true micrognathia. In true micrognathia, it is really a smaller smaller jaw, smaller size of the jaw. This can be of two types again, acquired or congenital. In acquired conditions or before acquired we have congenital. In this congenital conditions we have various syndromes like Perry-Robin syndrome, Treacher-Collins syndrome. In these conditions what happens is the development of the mandible or maxilla itself is hampered, hence the development is not complete, leading to smaller jaw. That is nothing but congenital micrognathia. We have something called as acquired micrognathia. The development is normal, but because of any secondary condition like a trauma to the condylar region leading to fibrous ankylosis or thus bony ankylosis can cause decreased growth of the mandible, especially during the growth phase. If the trauma occurs during the growth phase. So this is an acquired condition which is leading to micrognathia. And second condition is something like forceps delivery. Actually the growth is normal, child does not have any genetic abnormality or any maternal diseases are seen. Only because of this trauma to the condylar region during a forceps delivery, what happens is the fibrous ankylosis of jaw can occur, thus it can lead to micrognathia again. So in essence, it is usually this micrognathia is usually associated with various conditions like congenital heart diseases, Perry-Robin syndrome, Noonan syndrome, Treacher-Collins syndrome, orofacial digital syndrome, and we have juvenile chronic arthritis. Micrognathia of maxilla usually seen due to deficiency of premaxilla, and micrognathia of mandible is nothing but a small jaw, and this could have a steep mandibular angle, and also it could be because of agenesis of condyles. Acquired micrognathia, as we have discussed, is because of ankylosis of joint or a mastoid infection which has been draining into the which has been affecting the the joint, the condylar surfaces, this leading to micrognathia again. A second condition is macrognathia. Macrognathia, as the name itself indicates, macro, large, and gnathia is jaw. So the jaw is larger in size than the normal. So this is called macrognathia, and this macrognathia can be generalized one or localized one. Generalized, I mean it is both the jaws are involved, and localized, any one of the jaw could be involved in these cases. In generalized macrognathia, usually associated with pituitary gigantism, where growth hormone excess is usually seen before the developmental phase, and acromegaly could be seen. But this acromegaly, what happens? This is after the growth phase, right? In this acromegaly, it is again localized. Either of the jaw could be involved. Most commonly, mandible is involved, leading to class 3 relationship. The skeletal class 3 patient usually have mandible into the forward region, that is the skeletal class 3. Paget's disease of the bone, usually it also involves mandible. Leontosis ossea, it is usually in the fibrous dysplasia and also can be seen in case of Paget's disease, where in fibrous dysplasia maxilla is most commonly involved, leading to localized macrognathia. And we have another condition called as facial hemiatrophy. In facial hemiatrophy, there will be half of the face, one side of the face is decreased in its normal development. Most commonly seen in case of Perry-Romberg syndrome or progressive facial hemiatrophy. Even in case of progressive systemic sclerosis or scleroderma, we see a knife edge mark kind of thing called as coupe de Sabre. In this, there is actually a painless cleft. Because of this painless cleft, what happened in that region, in that particular region, there will be hemiatrophy. That is, there will be atrophy of that particular region of the face, leading to facial hemiatrophies. And the next condition, most commonly seen conditions or encountered condition, is cleft lip and cleft palate. It is usually associated with hereditary or environmental factors. Environmental factors again includes folic acid deficiency. These cleft lip or either cleft lip or cleft palate could be either syndromic or non-syndromic. In case of non-syndromic cases, only the patient will exhibit either with a cleft lip or cleft palate, and they will not have any other associated conditions. In case of syndromic forms, what will happen is there will be associated conditions like patient might have a depressed nasal bridge, patient might have decreased IQ, etc. Syndromic forms of clefts can also be usually encountered. In this syndromic forms, we can see Treacher-Collins syndrome usually most commonly seen. And then frequently this cleft lip and cleft palate can occur together. However, they can also occur separately. And in cleft lip, what happens is there is actually, we know this nasal process, median nasal process and the maxillary process will be fused to form a lip. In case of cleft lip, what happens is there will be defective fusion of this medial nasal process and the maxillary processes, leading to a cleft lip. This cleft lip again be classified into central one or lateral. Okay, in the central, what happens is the fusion between the nasal process and the two maxillary process will not occur properly. In case of lateral, the fusion between the two maxillary process is not properly occurring. In case of lateral, what happens? It will be seen to one side. Sometimes these lateral cleft clips can be again bilateral or unilateral based upon their occurrence. So this is a picture which is showing again we have based upon the development we have complete and incomplete. Complete is nothing but the cleft is extending till the nasal process, and incomplete only till the philtrum of the lip only we can say this incomplete based upon the development of the cleft. Based on involvement of other structures, it is again classified into simple and compound. This is a picture which is showing about unilateral cleft lip and bilateral cleft lip, and this is association of this unilateral cleft lip with cleft palate, and also association of your bilateral cleft lip with cleft lip and palate. Based upon the complications, it is again divided into complicated and uncomplicated. Complicated is nothing but there is oro-antral oronasal communication, and also extension into other adjacent structures is complicated in nature. The clinical features of these cleft lip and cleft lip, especially, patients usually will have, the kids usually, the infants usually have a problem with feeding. They cannot, do the suckling function, so there will be problem with feeding, and there are certain speech difficulties where phonetics such as B, F, M, P and V, the lip phonetics are usually not properly spelled in those cases. There could be collapse of maxillary arch. Because of this collapse of maxillary arch, what happens is it can lead to malocclusion. In the malocclusion, what happens is because of the maxillary arch collapse, there could be high palate, high arched palate, and there can be crossbite. Okay, crossbite in the posterior teeth. Missing of teeth can be seen, especially in along the cleft region. Supernumerary teeth also can be seen, and malocclusion as we have discussed. And management for it, optimum time for repair is, child usually in the cleft cases, initial lip surgeries are usually done within 10 months of time, and there is a rule of 10 in case of cleft lip surgery, that is 10 gram percentage of hemoglobin should be present, child should be 10 lbs of weight, and child should be of 10 months of age. So this is the rule of 10, especially in case of initial lip repair. Once this initial lip repair is done, afterwards, after the certain growth period of time, that is after 7 years or 8 years, we again do an aesthetic cosmetic surgery. The initial lip repair is usually done for making the child to have feeding, okay, to have the suckling function. And we have various techniques for the operation of cleft lip. These include Millat's method and Virolt-Blair operation. Virolt-Blair operation is most commonly used one. Now coming to cleft palate is because of failure in the fusion of the palatal shelves. Okay, the inner maxillary, premaxilla, and two palatal shelves will be there, right? There is failure of closure of or fusion of this palatal shelves can lead to cleft palate, and they are again complete and incomplete. Complete is where the cleft palate is been extending till the soft palate region. Incomplete, it is only extending till your hard palate or in the premaxillary region. And repair, this is a picture where we can see repaired cleft palate, and this because of the cleft palate, what happens, certain speech difficulties can be present. Feeding is again a problem. There will be communication between the mouth and the nose, leading to nasal regurgitation. Whatever the child takes into the mouth can come out from the nose. However, because of this condition present congenitally, that is right from the birth, the child can develop some adaptive mechanisms to prevent this nasal regurgitation. However, in these cases, cleft palate repair have to be done to prevent this feeding difficulties. And again, because of this cleft palate, what happens, the arch collapse is seen, and because of this arch collapse, however, the consequent malocclusion can also be other clinical features associated with cleft palate. So that is about cleft lip and cleft palate. Other developmental anomaly includes focal epithelial hyperplasia, also called as Heck's disease. This focal epithelial hyperplasia is usually known to be associated with HPV, that is human papilloma virus 13 and human papilloma virus 32, most commonly encountered in case of children. Normally, this focal epithelial hyperplasia or Heck's disease, the lesion is usually papillary in nature. It has a smooth surfaced one. Flat topped lesions can be seen. The characteristic appearance of cobbled stone or fissure appearance is seen in case of this Heck's disease. And developmental disturbances of tongue. In tongue, we have various developmental disturbances like aglossia, that is completely tongue itself is not present. Microglossia, as the name itself indicates, small tongue. This microglossia is again relative microglossia and true microglossia can be seen. Relative microglossia, because of the increase in jaw size, the tongue appears to be smaller in size, that is nothing but relative microglossia. And true microglossia, the tongue size itself is smaller in size. And then in macroglossia is again, as the name itself indicates, large tongue. This is again true and relative. True is usually seen in case of Becker-Whitman syndromes, and macroglossia can be seen in case of acquired conditions like amyloidosis, where there will be amyloid infiltrate in case of this in the tongue, in case of macroglossia. And relative macroglossia is a condition where the jaw is smaller in size, hence the tongue appears to be larger in size. Because of the decreased jaw size, and the tongue appears, though it is normal in size, it appears to be larger in size. That is nothing but relative macroglossia. Macroglossia can be easily observed by we can see these teeth indentations on the lateral surfaces of the tongue. That indicates that patient is suffering from, or patient is having macroglossia. Then other condition is ankylosglossia. Ankylosglossia is also called as tongue tie. Tongue tie is a condition where we have a lingual frenum, right? The floor of the tongue, or the ventral surface of the tongue is being attached to your floor of the mouth, right? In case of normal conditions, there is connected by a lingual frenum. In case of this ankylosglossia or tongue tie, what happens is this lingual frenum is attached more anteriorly, usually at the tip of the tongue. Ankylosglossia can be complete ankylosglossia or partial ankylosglossia. Complete ankylosglossia is the lingual frenum is almost attached to the tip of the tongue, where patient cannot protrude the tongue, and the lingual phonetics, the sound that tongue makes, can also be hampered in this case of this ankylosglossia. The treatment for this is frenectomy, where the lingual frenum is being incised to relieve that attachment between the floor of the mouth and the tip of the tongue, or repositioning of the frenal repositioning of the frenum can also be done for better speech and better functioning of the tongue. Next is fissured tongue. Fissured tongue is also called as scrotal tongue. And this fissured tongue, what happens is we can see number of fissures on the tongue. Okay, on the tongue we see multiple number of fissures, which is nothing but fissured tongue. It is also a developmental abnormality of the tongue. Usually patient will not have any problem with it, unless if there is more amount of food debris and patient is not maintaining properly. We can see blackish or white, grayish white or black discoloration of tongue can be seen in these cases of fissured tongue. And next we have median rhomboid glossitis. Median rhomboid glossitis is a condition where we can see a nice rhomboid shaped depapillation of tongue, especially in the at the region, at the foramen cecum region, usually associated with this median rhomboid glossitis. And then cleft tongue. Cleft tongue is a condition where a tongue is split into two. It is a developmental anomaly again. And benign migratory glossitis, also called as erythema migrans or wandering rash of tongue. In this condition we can see nice erythematous area with well defined margins, usually appears migrating from one region to another region. For example, if it is present at the tip of the tongue for some period of time, it can migrate into the posterior part of the tongue. Patient is usually asymptomatic in this condition. Sometimes it is usually associated with candidiasis, and in those cases antifungal treatment would usually help the patient in treating this candidiasis. This is about benign migratory glossitis. Now coming back to developmental disturbances of oral mucosa. We have various developmental disturbances of mucosa. One of them is Fordyce granules. Fordyce granules are nothing but ectopic, ectopic eruptions of sebaceous glands, usually seen on the buccal mucosa and also on the vermilion border of the lip. Usually they are non-functional in nature, and this, if they are occurring on the buccal mucosa, usually seen around the around your Stenson's duct region. Usually nice yellowish papules are usually seen. Greyish yellow papules are seen on the buccal mucosa, usually bilateral in occurrence, and if they are appearing on the vermilion border, sometimes they may pose a cosmetic effect. Okay, patient usually feels that there is a cosmetic problem with it, then we can go for laser ablation of these Fordyce granules. Otherwise any treatment is not required. And another condition is leukoedema. Leukoedema is a condition where there will be complete white patch seen on the buccal mucosa, and when we stretch the mucosa it disappears, and when we relax it, it again appears. This is nothing but leukoedema. It is also developmental in origin, usually no treatment is required for this leukoedema. And we see cervical cystic fistula also as developmental disturbances. This is because of entrapment of any epithelium during the developmental phase. We can see the cervical cystic fistula. Now coming to defects of your salivary glands, we have various defects of salivary glands, which includes agencies, that is completely absent salivary glands, and aplasia. Though the development is present, it is not completely in nature. The development is not complete. Atresia of ducts. Atresia of duct is the ducts are not properly developed. And these all conditions can lead to xerostomia or dry mouth. It is decreased secretion of your saliva. Okay, and these include the developmental defects of your salivary gland. Now coming back to our dental anomalies, we have various dental anomalies again, and these dental anomalies are can be classified grossly based upon their the type of condition. One is based on number of teeth. We have developmental anomalies based on number of teeth, which include supernumerary teeth. We have hypodontia, oligodontia, or endodontia. Endodontia is nothing but complete absence of teeth. Hypodontia is decrease in number of teeth. Oligodontia is again decrease in number of teeth. If it is less than 6 number of teeth, then it's called oligodontia. And hypodontia, if there are more number of teeth are absent, then we see as hypodontia. And supernumerary teeth are present. Supernumerary teeth are nothing but an extra tooth other than the normal number of teeth that has to be appeared. And the most common supernumerary teeth are mesiodents, which usually occurs in between the two central incisors. And other include distamolars, usually after behind the third molars of maxilla, and we see paramolars usually associated on the either side of the molars. Okay, usually seen in maxilla again. These are about supernumerary teeth. Supernumerary teeth, when we count, actually there will be more than the number of your the normal number of teeth. Sometimes the supernumerary teeth can be impacted in nature, that is they are present submerged within the bone. And this impacted teeth can pose a risk of dentigerous cyst. That's the reason any supernumerary teeth has to be consciously or cautiously follow-up has to be done for this supernumerary teeth. Based upon the size of the teeth, they're again classified as macrodontia and microdontia. Macrodontia is nothing but increased in size of the tooth, and microdontia is decreased the size of the tooth. Macro and microdontia again are relative and true micro and macrodontias. In macrodontia, taurodontism is one example. In case of this, the taurodontism is especially seen in case of lower molars, where the size of the tooth is usually bigger in size than the normal one. And microdontia most commonly we see peg laterals. Peg-shaped laterals are usually seen. Peg-shaped laterals, what happens is the instead of that nice wedge-shaped incisor, what happens, we see a conical shaped lateral incisors, which is an example of microdontia. And based on eruption of the tooth, we have something called as transposition. Transposition is a condition where, for example, in the premolar and we have a canine. In place of canine, premolar erupts, and in place of the premolar, canine erupts. So this is called as transposition. It is again an anomaly in the development of the tooth. And based upon the morphology of the tooth, we have various anomalies again. Fusion. Fusion is a condition where two teeth fuse together to form into one teeth. This is during the developmental phase, and when we actually count the number of teeth, we find one tooth missing in case of fusion. Okay, and the tooth is usually larger than the normal one. And we have something called as gemination. Gemination is a condition where one tooth bud divides into two. Okay, and these two teeth need not be of same size. If they are of same size, then it is called as twinning. In case of gemination, when we count the number of teeth, usually it is greater than one in number. Concrescence is a condition where two teeth are fused at the cemental region. In the root region, they are fused at the cementum area. This is nothing but concrescence. And we have something called as dilaceration. Dilaceration is nothing but curving of your root. Curving of the root is seen. That is at the root apex or at the middle 1/3 of the root, we see a curved roots. This is nothing but dilaceration. Dens in dente is a condition where we actually see invaginatus, also called as dens invaginatus, usually seen in case of your incisors, especially the lateral incisors. Dens invaginatus is nothing but the Leong's premolar, where we actually see another cusp-like structure appearing in case of premolar. Dens invaginatus most commonly seen in case of premolars. And Turner's tooth or Turner's hypoplasia, it is a developmental disturbance again. Usually if primary tooth is been assaulted because of any trauma or because of an infection, the underlying tooth bud, what happens is it at the time of development, if there need any disturbance occurs, the tooth bud, underlying tooth bud, after it grows, which shows a hypoplastic enamel. This is nothing but Turner's tooth, usually localized one single tooth is involved in case of this Turner's tooth. Now coming back to hereditary conditions, we have various hereditary conditions of teeth, which includes anomalies like amelogenesis imperfecta, dentinogenesis imperfecta. Amelogenesis imperfecta is usually affects both the dentitions. It is an autosomal dominant trait. There will be a mutation within the enamel gene, that is enamelin. In this, what happens is the tooth usually appears dark brown in color and the enamel layer is not properly laid. We see that enamel layer is being chipped off, nice border can be seen, and in these cases what happens is there are again of three types, which includes hypoplastic type, hypocalcified type and hypomaturation type. Hypoplastic type, what happens is the matrix that is being laid is not proper. In case of hypocalcified, the matrix laid is proper, but then it is not being calcified properly. The calcium and phosphorus that has to be laid, is that inorganic material is not laid properly in case of your hypocalcified clinical type. In hypomaturation type, what happens? The maturation phase is not proper in case of this hypomaturation. Here we see the morphology of the tooth can be slightly altered in case of your hypomaturation type. In hypoplastic type, the tooth is usually slightly softer in consistency. The enamel is slightly softer in consistency when compared to the other variants. And in amelogenesis, dentinogenesis imperfecta, it is a condition of hereditary or pallescent dentin, also called as cavity Pond's teeth. And dentinogenesis imperfecta, what happens? We see a nice bluish translucent enamel, a bluish translucent tooth can be seen. This is because of underlying dentin is defective, and dentin demonstrate accelerated attrition in these cases, that is high amount of attrition, very fast progressive attrition can be seen. Both teeth of both dentitions, all the teeth can be involved in case of this dentinogenesis imperfecta. There are three variants of this dentinogenesis imperfecta. Type 1, only dentinogenesis imperfecta without any osteogenesis imperfecta. Type 2, dentinogenesis imperfecta associated with osteogenesis imperfecta, where we see defect in other bony structures also, where the bones are usually bent. They are especially the lower limbs and upper limbs, we can see curved or crooked bone development can be seen. And type 3 is Brandywine type, which also have shell teeth can be seen as a characteristic feature of this Brandywine type of dentinogenesis imperfecta. So this is a picture which is showing dentinogenesis imperfecta, where the dentin layer itself, in the X-ray we can see the dentin layer itself is not laid properly in these cases. And we have something called as dentin dysplasia. In dentin dysplasia, we have two types, type 1 and type 2. Type 1 dentin dysplasia is rootless teeth, where or also called as radicular dentin dysplasia, where the root is involved, whereas type 2 is also called as coronal dentin dysplasia. In this coronal dentin dysplasia, we see a thistle tube appearance of the pulp chamber, and the treatment for this dentin dysplasia is usually a preventive care, and good oral hygiene has to be taken care of. And if the patient is having more difficulty with the aesthetics, then you go ahead with veneers or crowns in this cases of amelogenesis, dentinogenesis or dentin dysplasia. If multiple teeth are to be extracted, then in those cases we go ahead with prosthetic rehabilitation to maintain the occlusion and also aesthetics of the patient. And next condition is regional odontodysplasia, and the tooth affected by this regional odontodysplasia is also called as ghost teeth. Usually maxilla is most commonly involved in this condition, and anterior teeth are most commonly involved. Why this is called as ghost teeth is because it has an extremely thin enamel layer, and the dentin surrounds an enlarged radiolucent pulp. So more amount of radiolucency, which is surrounded by a thin radio opaque or white line. So it appears like a ghost, that radiolucency surrounded by a thin radio opaque line. The resemblance is usually like a ghost, and hence it is called as ghost teeth. So these are various anomalies that have been affecting the tooth. Okay, now coming to some syndromes which we commonly encounter. Treacher-Collins syndrome, also called as first arch syndrome or mandibulofacial dysostosis. It is a condition of autosomal dominant in nature. Usually this Treacher-Collins syndrome has various clinical manifestations like coloboma of lower eyelid. Coloboma of eyelid, as we all know, as a interruption within the eyelid formation, and then agenesis of one of the ear could be seen. Underdeveloped maxilla can be seen. Because of underdeveloped maxilla, there can be a cleft palate, or because of this we see a high arched palate, and also collapsed maxillary arch can be seen, leading to crossbite. Multiple supernumerary teeth can be seen in these cases, and we have underdeveloped external ear, no malar prominence, displaced ear can be seen, and also faulty dentition. This is a picture which is showing about Treacher-Collins syndrome. And the next one is nothing but Down syndrome. Down syndrome is also called as Mongolism. It is usually trisomy 21. In this Down syndrome, the most common features are patient exhibits macroglossia, micrognathia. We have mongoloid slant eyes, mongoloid type slant eyes. Patient's IQ is less than the normal, and patient has mental retardation and sexually underdeveloped kids can be seen in this case of Down syndrome. And one of the most common feature that we actually see is simian crease on the palms in case of Down syndrome. And patient usually exhibit endodontia, microdontia, enamel hypoplasia, and malformity. Periodontitis is usually most commonly seen in these cases, and dental caries are less commonly seen in case of Down syndrome. Patient exhibit flat face, large anterior open fontanelles can be seen, and open cranial sutures can be seen in case of this Down syndrome. So this is about various anomalies of face that occur during the developmental process, and usually these anomalies are most commonly does not require any treatment or management, but some conditions are usually aesthetically hampering, and some are occlusally and does not maintain the normal occlusion of the teeth. For example, like amelogenesis imperfecta or dentin dysplasia. In those cases, prosthetic rehabilitation might be required to maintain the occlusion, and aesthetic treatments like cosmetic dentistry can also come into place in those cases where we need aesthetic treatment, aesthetic management is required. So this is about various dental anomalies of face, or various developmental anomalies of the face. Thank you.